This is a story about a family and a community. Nikisha, an African American woman, is pregnant with her first baby. While so far her pregnancy is going well, Nikisha is worried. See, Nikisha has been thinking about her mother, SJ. SJ, the mother she never had a chance to know except through photos. This one is the one of the last taken. Is SJ happy and pregnant with Nikisha? Isha died shortly after childbirth. Ray, Nikisha's partner, is ecstatic to be a dad, but he too is worried. He's been doing his research and he's worried for Nikisha and his unborn child. Ray's little brother died when he was only 2 months old, when he was in his crib sleeping. He can still remember his mother's grief. Ray and Nikisha are doing their best to be informed, but they feel like there's little regard for their concerns and it seems like support just isn't there. Nikisha and Ray live in the second most populated county in Minnesota, Ramsey County. Before we dive into their story, let's talk about the population of Ramsey County. Ramsey County has a total population of 552,352 people. 61% of its population is white non-Hispanic, followed by 15% Asian non-Hispanic, 12.1% Black or African American non-Hispanic, and 7.5% of Hispanics of all races. I am also including here the Hennepin County data. Hennepin County is the most populated county in Minnesota and neighbors Ramsey County. In order to meet the criteria for numbers in running the perinatal periods of risk analysis for fetal infant mortality gaps, both counties needed to be included. Together, these two counties include the Twin Cities, St. Paul in Ramsey County, and Minneapolis in Hennepin County. In June of 2016, St. Paul Ramsey County Public Health Family Health Division applied and was selected to be part of the third cohort of the CitiMatCH Birth Equity Institute. The local health department reached out to several community partner organizations in an effort to be more impactful and supportive in leveraging community efforts addressing health equity in birth outcomes. Representatives from several organizations came together in the formation of the Birth Equity Community Council, or BECC. These group of leaders attended the CitiMatCH Birth Equity Institute and began the work of BECC of engaging community and identifying initiatives. Through the utilization of the Ready, Set, Go framework developed by CitiMatCH, BECC was able to assess community readiness and capacity, examined local data, and created a logic model in and with community to implement strategies to promote health and healing targeted towards the birth disparities found within the local data. A key question arose: how do we partner data with community voices in creating initiatives to reduce infant mortality inequities and improve infant and maternal birth outcomes in the US born and foreign born Black populations? BECC was aware that the same racial disparities that persist nationwide for birth outcomes were mirrored in the local community. The focus was on disparities existing in the US born Black and foreign born Black community and the American Indian community. But because the goal was targeted for initiatives to be centered within the community, they were very intentional, assuring data was inclusive of community experiences and voices. For this reason, BECC hosted a series of 50 community participatory dialogues around envisioning victories for initiatives that the community felt would make an impact against these disparities. For the quantitative data, BECC utilized the perinatal periods of risk analysis, or PPOR, developed by CitiMatCH. In the PPOR, the underlying assumption is that if one population can have good birth outcomes, then all populations should be able to have the same good outcomes. PPOR is a way to understand what is happening with infant and fetal deaths. It is a multi-phase approach to help communities use data to reduce infant and fetal mortality. The analysis requires a minimum number of deaths in the population of interest or target population. For this reason, Ramsey County's Birth Equity Community Council enlisted the help of Hennepin County, who contributed their birth mortality data to be included with Ramsey County's data. PPOR is different from other approaches by including fetal deaths in the analysis and by dividing the deaths into four areas that help communities determine where to concentrate prevention efforts. The four categories are maternal health and prematurity, maternal care, newborn care, and infant health. In PPOR Phase 1, the fetal and infant deaths for both the study and reference groups are divided into the four perinatal periods of risk, and rates of death are calculated. Then the difference between the study and reference group rates is calculated. This difference is called excess mortality or the opportunity gap. Another way of describing the gap is to calculate the number of deaths that would not have occurred if the gap did not exist. PPOR Phase 1 analysis showed that infant health followed by maternal health and prematurity were the two periods with the greatest excess mortality for babies of US-born Black women. For foreign-born Black women, PPOR Phase 1 analysis showed that infant health and maternal health and prematurity were the two periods with the greatest excess mortality for babies. This is to say, if the PPOR rates had been the same between the study groups and the reference group from 2011 to 2014, 94 infant and fetal deaths to African American women and 78 to foreign born Black women would not have occurred. The infant health period was noted to have the largest disparity for US born Black women. Further analysis of the infant health period revealed that sleep related deaths made up the majority, and that the rate of sleep related deaths was 3.5 times greater for infants born to US born Black women than to white women in Ramsey and Hennepin County. If the rate of death for infants born to Black US born women was the same as the rate for white women, 14 of the 20 babies who died from sleep related causes would have lived. Several of the sleep-related deaths, 60%, had contributing factors indicated in the vital records, of which mentioned unsafe sleep environments, including co-sleeping and prone position. Remember Ray? His little brother died in his sleep. Maternal health and prematurity period was the largest for both study groups. Kitagawa analysis showed that large numbers of preterm births was the main pathway for US-born women. Further analysis in Phase 2 of the PPOR pointed to contributing factors for preterm births, with the greatest being maternal hypertension. Remember Eshe, Nikisha's mom? She died shortly after childbirth from preeclampsia in the postpartum period. For foreign-born Black women, the pathways were split between large numbers of premature births and poor survival of premature babies. While the data told us part of the story, Beck understands that individuals do not experience disease and health inequities alone. One of the underlying wisdoms of Beck can be explained by epidemiologist Nancy Krieger's concept of embodiment. That is, we, quote, literally embody biologically our lived experiences in societal and ecologic context, thereby creating population patterns of health and disease. This is to say that social historical constructs of group membership and the effects of hegemonic institutional structures are reflected and need to be taken into consideration in the explanations of population health disparities. Community wisdom is central to the work of Beck. Beck understands that even in the face of hierarchies of power that often exclude the voices and cultural consciousness of communities affected, historically communities have an innate wisdom and often organize in spaces that promote agency. This wisdom was evident in the Envisioning Victories gathering as community came together to voice their concerns around safe sleep practices, maternal care access, trust in providers, and lack of support for fathers. From these many conversations, many initiatives began. Public service announcement around safe sleep created by community members, training of doula men in the Doula for Dads program to support fathers, the implementation of Parents as Teachers home visiting program within Ramsey County Public Health, the creation of Club Mom and Club Dad to provide further support and connection to community. By partnering data and community voices in our initiatives, BECC has learned and proposes that programs seeking initiative implementation around birth equity must address the intersectionality of social, cultural, historical determinants of health embodied in populations and experienced in communities. In breaking down and making accessible power structures, community members and partner organizations are able to access their civic agency. As Nikisha and Ray enter their parenting journey, with the memory of their loved ones and the history of their family and culture together, feeling siloed, the Birth Equity Community Council hopes to bring them in connection with community. This result is still an embodied individual, but one that is connected community with increased civic agency. Together in community, merging data with community voices and experience, that can help change the historical trajectory of maternal and infant birth disparity outcomes.